what we've done here is just, we've made points between the symphysis and the sacrum, or the coccyx, and the two ischial tuberosities, and drawn a line between them to divide them into a front triangle and a back triangle. You can guess which one's the UG and which one's the anal. Now these are not flat across there. They're angled as it shows in this bottom, the right side picture. Okay, so they're not flat across there. I mentioned this before, that the superficial and deep fascia of the abdominal wall, the Camper's and Scarpa's fascia, is continuous around the penis as the dartos, and then continues on to the perineum as Colles fascia. The superficial fascia here of Colles attaches right there. That's called the perineal body. The perineal body. That's the thing that's between your vaginal opening and your anal opening, or in males between the bulb of the penis and the anus. That's the perineal body. Because it's attached there, if bleeding occurs up underneath that fascia there, then what's going to happen is it will come down around the scrotum, but will not go past that attachment in the perineal body. If you see that, you've probably done wrong. What more do you need to say? All right. Now, anatomists describe different spaces in the peritoneum. So let me try to explain this. It's actually very simple. Going back to the other day, here's the obturator internus. Off of the obturator internus, you'll have the pelvic diaphragm, which would be the iliococcygeus. Now let me tell you where this picture is taken. We're up here at the bladder of the prostate, so we're in the in the urogenital triangle, right? We're in the front part. So what we're doing is taking a coronal section, and we get the pelvic diaphragm. Remember, the prostate is going to sit right on top of it, because you found, no, who was it yesterday, found the prostate from above, right? Who was that yesterday? One of the guys. The seminal vesicles, that was you guys. Yeah, the seminal vesicles were draining into the prostate. So you had your hand on the prostate from above. So your hand was up here, right, superior to the pelvic diaphragm. I mentioned yesterday that the prostate sits on the urogenital diaphragm. Remember I said that yesterday? Well, today we're going to talk about the UG diaphragm. Today's discussion is on the UG diaphragm. The UG diaphragm is a muscle that actually covers this space right here. The UG diaphragm covers that triangle. All right? Now, it's called the deep transverse perineus muscle. The deep transverse perineus muscle, that is the UG diaphragm. Deep transverse perineus muscle. Now there's another muscle that runs right there with it, and that wraps around the urethra. It's called the sphincter urethrae. So you see this little gap right here between the two sides? That hole in there is occupied by a round muscle. You'll see this later on. So there are two things right there on the same plane. One is the deep transverse perineus muscle, and the other is the sphincter urethrae. This is skeletal muscle under somatic control, so you have control of it. This sphincter urethrae is your external urethral sphincter. It's the one you contract to keep from peeing on yourself. The internal urethral sphincter is up here in the bladder. If you got a full bladder, this is already opened. You're just holding it in by the external sphincter, which is in the UG diaphragm. Now the UG diaphragm has a membrane on it, a fascia, above it and below it. That creates a space called the deep space. So the deep space actually contains the UG diaphragm, which is made up of the deep transverse perineus muscle and the sphincter urethrae. You want to say that again? Mm-hmm. All right. These two membranes, if you were to take the muscle out, you would have a gap there, right? So if we're going to take the deep transverse perineus muscle and put in there between those membranes, and then you've got the sphincter urethrae, these two together form the UG diaphragm. They occupy the deep space, which is formed by these two membranes. It's a stupid designation. I don't even know why they have it, but that's what they call it. When you refer to the deep space, you're essentially referring to the investing fascia of the UG diaphragm. That's all it is. Now, the most inferior fascia is called the perineal membrane. So this fascia on that side right there is called the perineal membrane. Right there. So if I were to turn you upside down and remove your skin and fat, and I can see your perineal membrane. I'll show you, I'll prove it to you in just a minute. Okay, follow along. No, I mean not. No, I will prove it to you in just a minute. Hanging off of the perineal membrane is your external genitalia. Now this happens to be a guy right here. So there are three things that form the external genitalia in a guy. These two out here and this one. We're going to describe them here in a minute. This one right here. This is where you see where the bladder's coming down through the prostate, I mean the urethra's coming down through the prostate, and here it's entered the penis, and from here it's going to go out there, right? Out of the plane of the board. That's the angle right there, that 90-degree angle right there. You're going to make the turn to go up through the membranous urethra. Remember I mentioned that yesterday? That's the part of the urethra that's within the UG diaphragm. Now in women, you still have these two, but this one right here is divided in two because you have a labia on each side. So in women, you would actually have four things going across there. I'll show it to you in just a second. Your external genitalia, whether they be labia or penis stuff, occupies or sits in the superficial space. So this is the superficial space. The UG diaphragm occupies the deep space. More superficially is Colles fascia. Right here, yeah, it would be more dartos right there. Or even scarpas. Doesn't really matter, it's the same layer. And this would be fat, and there's your skin. All right, now let's name these structures. These two things right here that are adhering to the ischiopubic ramus. You see this gap right here? What is that gap in the bone? Why is that gap in the bone? Now we're anteriorly, right? What gap do you have in your bone right here? The obturator foramen. So what we're doing is we're cutting through, you're cutting through the hole. So you're seeing the bottom piece and the top piece of both. That's why there's a gap there. This would be the obturator internus muscle. That's the pelvic diaphragm hanging off of it. That would be the pudendal canal right there. Now, hanging off or attached to the ischiopubic ramus, because that's the bottom part of that obturator foramen coming up to form the pubic symphysis, right? Is this structure right here. This is called the corpus cavernosus, or cavernosum, it doesn't matter. Women have them and men have them. This is erectile tissue. Around the corpus cavernosum is a muscle called the ischiocavernosus. Corpus means the body, the erectile body. Ischio because it's connected to the ischial tuberosity. I mean the ischial bone, ischio. So the muscle around it will help propel blood that's in the erectile tissue. It squeezes it to make the downstream tissue firmer or more hard. Okay? Male or female, it's the same thing. Now this guy right here is called the corpus spongiosum. Corpus spongiosum. Men have them and women have them. Surrounding the corpus spongiosum, which is erectile tissue as well, is the bulbospongiosus muscle. Like the ischiocavernosus, it contracts to force blood to make the erectile end target more firm. This is the picture in females. You have the same thing. You have the ischio and the bulbo. In females, the corpus spongiosum and the bulbospongiosus are within the labia majora. The labia majora and the scrotum are embryologically related. So the corpus spongiosum and the bulbospongiosus that surrounds it are in the labia majora. So if we look at it here and put it all together from the bottom, and this is what your cadaver is going to look like today. Okay, you're going to remove the skin here. Is what is that muscle right there? That's part of the pelvic diaphragm. I'm sorry? I can't see because of the glare. Yeah, that's probably coccygeus right there. Part of the pelvic diaphragm. Here's the perineal membrane. So because the external genitalia hang off of it, underneath the perineal membrane would be the deep transverse perineus muscle. Here it is in the female. Perineal membrane, underneath that is going to be the muscle. Here's the ischiocavernosus muscle, the bulbospongiosus muscle. Over here, the ischiocavernosus muscle, the bulbospongiosus muscle. The bulbospongiosus muscle wraps around the bulb of the penis. So there's one more muscle there that we need to talk about. Here's the perineal body. I said it was behind the root of the penis, or between the penis and the anus, or between the vaginal opening and the anus. That's the perineal body. There's another little muscle that's very superficial, and usually it gets cut away, and it's a thin muscle. This is called the superficial transverse peroneus muscle, right there. Superficial transverse peroneus muscle. It just runs from the perineal body laterally to the ischial-tuberosum. This is what you need to pay attention to, is that if you get a gunshot wound to the perineum, what tissues you're going to go through in order. So you need to get this relationship down, that you've got the pelvic diaphragm is there, and then underneath it is the UG diaphragm. Underneath that's the perineal membrane. Underneath that are the roots of the external genitalia. Underneath that is the dartos or Colles fascia. Now get that down. Now if we take off the muscles, then what you have here is just the erectile tissue. You have the two pieces of erectile tissue here. These are called the corpus. By the way, all of the erectile tissue is corpus. So the corpus cavernosa and the corpus spongiosa. I always remember the spongiosum as the part right over the penis, because SpongeBob has a mouth. It works for me. SpongeBob, there's no urethra in the ischios, or the crus out here. You know, you can also call this crus. It's corpus cavernosa. You can also refer to it as a crus. But I always remember the SpongeBob as having a mouth. That's the one with the urethra in it. You don't follow me?
No.
Can you elaborate a little?
Let me go back.
Can you elaborate?
So there's SpongeBob's mouth. Oh, yeah. Yeah. Spongiosum, SpongeBob, and a hole in it. That's the urethra. Are we okay with this? All right. Memorize it however the hell you want to. I don't care. All right, there are a couple of glands that you need to know about, you women have. Two of them, one on each side, are located behind the bulbospongiosis. These are called Bartholin's glands. They're located in your labia majora and help lubricate during intercourse. You have two other glands that you'll never find up here associated with the urethra. They're called Skene's glands. Skene's glands are very tiny, you won't find them. That helps lubricate this area up here as well. Right? The Bartholin's glands, they dump into the vagina, the very opening of the vagina. So if we remove all of the erectile tissue and we get down to the level of the UG diaphragm, this is what it looks like. Okay? Very, very simple here. The deep transverse peroneus muscle, we've removed the membrane and everything here. This is all you have left. Now there is a gap up here in the top that can transmit vessels, particularly a vein, a large vein. Just keep that in mind for later on. Here's the sphincter urethrae. Around the male, around the female, it's up here. Remember that the urethra is in front of or anterior to the vaginal opening. Any questions about this? All right. Here's another slide, is one that puts it all together. There's the perineal membrane, there's the deep transverse peroneus muscle. Superficial transverse peroneus, bulbospongiosis, ischiocavernosus, clitoris, prepuce, P-R-E-P-U-C-E, Prepuce or the hood over the clitoris, bam, that's it. Now you know it all. All your junk, it's that simple. You'll see it later on, but appreciate this. Here's the ischial cavernosus muscle. Remember that surrounds the corpus cavernosa, which is erectile tissue. You see how that runs up the ischiopubic ramus here? There's the symphysis up there. There's a ligament, a suspensory ligament, that the two corpora cavernosa come up from each side and go to form the clitoris. That's how that works. And then that ligament holds the clitoris to the back, to the underside of the pubic ramus. This would, of course, be our pelvic diaphragm right here. Today, this is the dissection you're going to do today. Keep in mind that this area right here is completely full of fat. And you just have to take your the handle to an instrument like a scalpel and just rake it out of there. It's, there's a lot. All right, here's, you need to go over this slide right here, make sure you can identify the pieces and parts. What space is that right there? That's the deep space. What space is this right here? That's the superficial space. What fascial plane, what fascia is that right there? Oh, it says it right there. Pelvic fascia, okay? Here's the ischiocavernosus muscle, the bulbospongiosus muscle. And this illustration kind of puts it together here. Now, the one thing I want to add to this is that, remember the pudendals. I said yesterday they go out the greater sciatic foramen and turn and go back into lesser sciatic foramen. You can see them right here coming back into lesser sciatic foramen in the anal triangle. You can find them very easily right here on the lateral edges of the anal triangle. They're going to proceed all the way forward to form the vasculature on the top or the dorsal surface of the penis or the dorsal surface of the clitoris. We'll go over the vasculature in just a second. Any questions about the UG triangle? Here's the anal triangle back here. It's full of fat. I'll say it again. You'll love it by the end of the day. It's full of fat. It's called the ischioanal fat. We talked about the puborectal sling yesterday. This is an illustration of what it kind of looks like. It puts that angle onto that I drew on the board onto the rectum right here. And during defecation, it relaxes to straighten this angle out so stool can move more freely. There's another little thing that you should know about, and that is this right here. Going from the back of the anus to the sacrum, or the coccyx, excuse me, is the anococcygeal ligament. The anococcygeal ligament essentially just anchors the rectum or the anus in place. Anococcygeal ligament. You'll probably see it today. This is what it looks like right here. This is what diaphragm? Pelvic diaphragm. That is the UG diaphragm. Remember yesterday I said that infection from the anus can get out in here and spread deep to the UG diaphragm. It can actually go on the other side and spread deep to that one. Perianal abscesses are about as common as acne. Everybody has if you don't have a perianal abscess, You probably need to go out and get you one this afternoon. I mean, everybody has them. You see them at least once a week in clinic. I'm always very cautious about perianal abscesses because what feels like something, the size of a pecan, you stick a scalpel in it to drain it, and before you know it, you can take a 6-inch cotton tip applicator, it's that long, and you can stick that in the hole and run it all through there. These abscesses, I never mess with these things because they can just be, what appears to be small, they can just be huge. You can get buckets of pus out of these things because there's so much room down here. Okay? I mean, if it's absolutely well localized, I don't mind incising them. But if it's, if you have an obese person and you've got not a well-defined abscess, I don't do that. Because you don't know where that stuff's going to go.
Where do you send them?
General surgery. Take them to the OR. Then every once in a while I'll send them to a surgeon. They'll open them up in the office. But, they have better insurance than I do. So let them take the liability for that. I've seen one time a friend of mine did one on a Friday, and it got infected, and she wound up with necrotizing fasciitis of the scarpas and Colles, scarpas and Colles fascia. She wound up having to go in and have this entire area opened up and excised. It was just a nastiest mess. So I don't like playing with perianal abscesses, especially if they're diabetic. You got diabetes and a perianal abscess, goodbye. I'll make a phone call for you. Yeah. Any other nurses in here? Any other nurses in here?
They're the worst.
You've seen some nasty, they can be horrendously nasty. You think, oh, this is just a simple little thing. You're going to stick a little, because they really hurt. You stick a little scalpel in it and, go home, you're a hero. It turns into just a nightmare.
I had one shoot on me.
Ew.
You have what?
Like the stuff from the abscess go all over me.
Oh, yeah. By the way, a point you need to appreciate is abscesses are typically under pressure.
Yeah.
So that whenever you poke it with a number 11 scalpel blade, you want to make sure it's pointing at somebody besides you. Or I always put my hand over it like that. So if it shoots out of there, it doesn't shoot on me. Everybody's been hit with that stuff before. But, just get to the point where you open it with your hand over it or facing away from you.
So what causes it? Just like bad hygiene or what?
It's it starts out as an infected hair follicle and, a duct, a duct. You got a bunch of sweat glands and stuff around here around your butthole. And that's an anatomical term. I have a doctorate in anatomy, so I can say that. Like a ball sack, they're anatomical. You get abscesses anywhere where you have hair, really. You can see the pudendal nerves coming through the lesser sciatic foramen right here. One of the first branches that come off of the pudendals are the inferior rectal artery, vein, and nerve. These things are located in the fat, and they go over towards the this structure here. Let me ask you a question. The nerve here, is it somatic or visceral?
Somatic.
It's somatic. When I say it's going over to here, what is it? Where is here? The external anal sphincter. Does it say it up there on that thing? Good, you got it right. The external anal sphincter. You had Mexican food for lunch. Your internal anal sphincter has let go. You're holding on with all your might thinking, oh crap, we got another 19 minutes. That nerve, that boy right there, are only thing keeping you in this class. Okay? And you contracted this too to suck it all up inside. All right.
Yes.
The nerve continues and will divide. There's a deep branch and a superficial branch. The superficial branch is called the perineal nerve, and it supplies the superficial tissues here, the skin in your perineum. So the sensory of your perineum, you know, your labia, your scrotum, and the surrounding areas is through S234, the pudendal nerve. Now the deep branch is going to continue and resurface onto the dorsal surface of the penis and clitoris, and we'll see those in just a minute. They're called the dorsal nerves, and they provide the somatic sensation of your clitoris and of your penis, one or the other. Any questions about this? You know, it looks complicated, but actually it's rather straightforward if you just let it flow through there like that. Here's an illustration of where the nerve goes. The superficial branch gets all the hanging down stuff, and the deep branch comes up here to eventually become the dorsal nerve of the penis or dorsal nerve of the clitoris. They all originate from the pudendal S234. S234 also supplies the pelvic diaphragm and the UG diaphragm. S234 keeps the pelvis off the floor. You contract it to keep it off the floor. Huh? Is that a test question? You want that to be a test question? What nerve keeps what spinal cord segments keep the pelvis off the floor? 2, 3, or 4, or all of the above?
That would be nice.
So nice.
We had exam questions like that.
Yeah.
What a dream.
All right. Now,
What muscles would
I throw this up here because now we're inside the pelvis looking out. Here are the nerves going out the greater side of the foramen, coming back in through the lesser side of the foramen, which is formed by the two ligaments, the spinous and the tuberosity ligaments that create foramen out of the notches. And I went over yesterday. I think today, well, I know today, when we have when we do the anal triangle, the cadaver will be prone, and you're going to have to remove the gluteus maximus. You'll fold the gluteus maximus out like this, leave it attached laterally. But you got to get it out of your way in order to see those ligaments from the outside. I'll help you, because if you don't watch out, you can cut right through those ligaments. You need them in place so you can understand the pathway of this nerve in order. Okay.
Just to make sure I understand this right, this is somatic, right? The S234.
Yeah, it's a branch of the, it comes off the sacral plexus. It'd be just like the ulnar nerve. Now, it's going to contain sympathetics because you have sweat glands, erectile muscle, pili muscle. I guess you have erector pili muscles, but you definitely have blood vessels and sweat glands in your this area. Right. Here's an illustration of the three parts of the urethra that I mentioned yesterday. The prostatic, the prostatic, the membranous, and the spongy urethra. There's one thing I want to add to that, and that is located in the deep space is a gland on either side. That gland has a duct that drains into the urethra. The gland males is called the bulbourethral gland. So if I asked you, what are the three things in the deep space, you would tell me the deep transverse perineus muscle, the sphincter urethrae, and the bulbourethral glands. Those are the three things that you'll find in that space. Here's a detail of it. What they've done is they've cut through there, and it's kind of interesting to see some of the pieces and parts. Here are the openings of the bulbourethral glands right there into the urethra. If we go back up here into the prostate, you see the two openings of the ejaculatory duct, one on each side. This ridge in the middle here is called the seminal colliculus. And in the middle of the seminal colliculus is a little pit. That pit is called the prostatic utricle. The prostatic utricle in a male is the same thing as the uterus in a female. That's all we've got left of our uterus is that little pit right there. So when you're on Jeopardy, what is it, analog of the uterus? It would be the prostatic utricle. The suspensory ligament in a male is like the suspensory ligament of the clitoris in the female. It suspends the stuff from the pubic ramus. It's just a continuation of the deep fascia. This is a sort of a summary of the nerve and vascular supply. There's one exception though, and that is the vascular, a lot of the venous blood, there's a pudendal vein. So a lot of this stuff, like the scrotum, the labia, the perineal region, is going to drain through that pudendal vein. The one exception though is the dorsal vein of the penis and dorsal vein of the clitoris. Instead of going into that pudendal vein, it comes straight out and deep to the arch of the pubic bone and drains into the prostatic plexus in males, which is a network of veins around the prostate, or the cervical plexus in females. Now clinically, I don't really think that has a whole lot of significance, other than knowing that there's a different venous drainage from the scrotum and labia from the penis and clitoris. When you look at the vessels of the penis, there are superficial and deep vessels. Now, this membrane right here is called Buck's fascia. That's the deep fascia that wraps around the penis. You can see it right there. Buck's fascia. So when you peel the skin off the penis today, this is what you're going to see. Now, there are superficial veins that run between the skin and Buck's fascia. If you look at an erect penis in a guy right there, you see veins on his penis. Those are the superficial veins because they're between the skin and that fascial plane. If you remove that fascia, though, then you'll get to the veins that really matter, and those would be those that are involved in erection. But particularly, there are 5 structures deep to Buck's fascia. There's a large central vein, it's called the deep dorsal vein of the penis. That's what's going to drain into that prostatic plexus of veins. On either side of it is the dorsal artery of the penis, and on either side of that are the dorsal nerves of the penis. All the sensation, the somatic sensation, is carried over those 2 nerves, which are the terminal branches of the pudendal. Right? It's the same with the clitoris. It's just the clitoris is so small, you can't find these things, but you should be able to find them in the males. when you do it, when you transect the penis today, this is what you're gonna see. You'll have the two crura, or the corpora cavernosa, and it's spongy tissue. It looks like loam. You know, if you squeeze it, you can tell it's spongy. It's erectile tissue. And then down here is the corpora spongiosum, with SpongeBob's mouth. That's the urethra. It too is erectile tissue, but look how small it is, or less it is, versus these big boys up here. If you had erectile tissue that was so big on the bottom, it would close off the urethra. So, there you go. There's also two arteries that you'll find right in the middle of the corpus. Those are called the deep arteries of the penis. Right there. All of this is very easy to find if you just transect the penis. One of the funniest things on a practical I ever did, and I talked about it the other day. Who was I talking to? He was in her class. I took a penis and I cut it, and then I cut a piece out, right? So, and then I took that piece and laid it on one of those lunch trays, and I had something tagged. You know, I had like a pin in here or something, and, you know, identify. And she put, and I won't ever forget it, she put carina. When you stop and think about it, it kind of looks like a carina, you know, with that being the central thing. We had a lot of fun with that concept of how you would have a penis at the level of the carina. I'm just saying. It was not a mutation.
Brad, how would that happen?
Brad, how would that?
I'll draw you a picture at the break. All right. Any questions about any of this? You know, erection is not a function of increasing the arterial blood flow into the area. Erection is a function of decreasing the rate of venous outflow. So there's congestion on the arterial side.
So as far as the corpus tissues, is it kind of like a lot of capillaries, or is it just holes that the blood gets stuck in? Like what's it made out of?
It's more sinusoidal. Yeah, there's blood in here. Yeah, there's blood. They're not these are not capillaries. Capillaries are too small to even see. These, it'll look like a sponge. It will truly look like a sponge. And when you squeeze it, you'll see that, you know, fluid comes out of the sponge. Now, on occasion, an erection will not go away. An erection, if you listen to the Viagra commercials, they always say, for erections lasting more than 4 hours, contact your provider, and everyone else you know. So, a prolonged erection is called priapism. Priapism, priapism. And the way you fix priapism is you use different types of vasoactive substances to cause the penis to drain. I don't want to get into it more than that. Yes, ma'am.
I was going to say, in the emergency room, we had a case of priapism come in due to trazodone.
Trazodone, yeah.
And the urologist had to come in, and he drained one of the veins in the superficial portion of the penis.
Yeah,
He
so
pulled like 90 milliliters out.
90?
90.
90?
Yeah.
You get a number?
We counted.
No, I'm kidding with you.
No, because we had to keep track of how much he pulled out.
90 milliliters, that's like a...
That's a lot. I mean, it's a lot.
He's like, I got mine.
And sometimes what they'll do is just stick a needle directly into the corpus and just drain the blood directly out of the corpus and not try to go into a vein. They just stick it right in the corpus.
Is a symptom of some kind of injury.
Here's a, for those of you that haven't been around a lot of peni, they come in two forms. There's a circumcised. Some people have, you know, there's been around a lot of them. I'm behind one every day.
Oh my
Well, I'm not so certain about Austin.
I like something else, like, asshole.
They can come circumcised or uncircumcised in reference to whether or not the foreskin has been surgically removed. I was listening to an NPR show the other day about circumcision. It was really interesting. And it being a religious tradition, but it's Jewish. So why are so many Christian Americans circumcised? It doesn't even make sense. I mean, the whole purpose for circumcision had to do with with a Jewish tradition. How in the world did it turn out that probably 99% of American Christians are circumcised? And it was kind of an interesting talk. All right, so here we go. Now I want you to understand this picture here. What we've done is we pulled the erectile tissue off of the spongiosum tissue. Here's the bulb of the penis here, and here's the corpus spongiosum. It ends as the glands down there. The glands have surrounding it a corona. It was on another slide. I'm not sure if glands, and there's the corona right there. These are obviously not apparent in an uncircumcised person. This illustration here is taking the two ischio, or two corpus cavernosa, where they come together onto the top of the penis. You see they have two of them up there. And that inserts into the back of the glands. You won't be able to dissect this away today, but that's how it's structured. Any questions about that?
So the
You put it all
corona,
together here, there's the bulb, here are the two crura, or that part that's adherent to the ischiopubic ramus. Together they form the shaft and gland. Above that is going to be the prostate. Right there, what would sit right here? Yes, the sphincter urethrae and the deep transverse perioneus muscle. The prostate sits on the UG diaphragm. Katie?
so the corona is just the outer layer of the glands?
It's this ridge that goes all around there. The glands is attached to the back of the ridge right there. You'll see it when I show you the circumcision slide, how that works. So if you pull back, if you have an uncircumcised penis, and when you examine an uncircumcised penis, you will take the penis and hold that right there, like that's the penis. You'll take it, hold it up. So you'll hold it like that, and you'll push the foreskin back like that to expose the glands, and the foreskin is going to be attached to the backside of that corona. Okay. You can let go. It's your fault. It's not my fault. All right, so let's talk about the testicles and stuff here for a minute. The testicles are full of miles and miles of seminiferous tubules. I encourage you to take a testicle and cut it and size it with a sharp scalpel, a clean, a good sharp scalpel, and size it long ways. And open it up, and then take a pair of fine scissors or something, or pickups, and just reach in there. And it doesn't look like you can do it because it looks spongy, and just pull up. And you can pull up these seminiferous tubules. It's amazing how many miles of tubules are in there, and within those ducts, within that tubule, that's where you'll have a sperm formation. Sperm collects, all these ducts will open up into what are called the rete testes. The rete testes will drain into the efferent ductules, and they drain into the head of the epididymis. Now, you're not going to be able to distinguish between the rete testes and the efferent ductules, but that's the pathway. From the head, the sperm will travel down. You see how coiled this is? I mean, to tell you the truth, a sperm has to travel a mile before it ever sees the light of day. So, this would be the tail down here, okay? And then it will enter the vas deferens and start its course, okay? There's one other thing you'll hear about. This thing right here is an embryological remnant. It's called the appendix testes. The appendix testes can twist, and just like a torsed ovary or a torsed testicle, that thing too can become ischemic. And when it does, it turns blue. So when you look at if somebody comes in complaining of excruciating pain on one side of the scrotum, and you look at the scrotum, you can see, sometimes through the skin, a blue dot, deep to the skin, like shines through, sort of. It's called the blue dot sign. It's pathognomonic for a torsed appendix testes. Kind of cool. The blue dot sign.
What do you do?
Nothing. Let it die. Which it will. And the blue dot will go away. The blue dot is ecchymosis. It's just dying. This is the vascular supply of that area, truly impressive. Here is the outermost covering of the testes, again, for the 900th time, is the tunica albuginea. And you notice right up here, I think they inside the tunica vaginalis in order to get to the testicle itself. Yep. You okay with this? Okay. Any questions? Yes, ma'am, Katie.
Is the visceral tunica vaginalis the same as the tunica albuginea?
No, it's separate. Tunica vaginalis is thin. It's very thin. The tunica albuginea is white and it's very thick. And as a matter of fact, if you look at the penis itself, the tunica albuginea continues up onto the penis. And it's very thick and it's white in appearance.
That's because the picture in the top left, it looks the same. It might just be not on that one, sorry, in the one we were on. But that could just be the way it was drawn.
Well, they've removed, they've opened up, there's the visceral layer, that's the parietal layer. So underneath the visceral layer is the tunica albuginea. The people, why don't you take a break and then we'll go to the female.